is subject to the safety in the
If you could send them on to us. One of the questions that we have over here, which is open to the panelists, where somebody's asked, what do you mean when you say that a hearing aid is not working, and then can we put an implant?
What's the question? Hearing aid is not working.
Yeah, what do you mean that the hearing aid is not working? Whether, that it's not effective for the child or for the person who has a hearing impairment. So then can we just put in an implant?
Hearing aid is not working is, and I think it means that it's not benefiting the child.
Correct.
So you really have to try for quite some time, give therapy in terms of evaluating the child before and after putting the hearing aid, maybe for stipulated time, maybe 3 months, and see the development in terms of speech and language or auditory behavior pre and post hearing aid fitting. And if it proves that there is no or very negligible amount of improvement in the child, then probably you say it's not useful, not before that.
Could you specify tests that can be used for the same?
And if the child is non-verbal, there are tests like a low verbal version of early speech perception test, where you just say ah and hop hop and the child has to repeat. That could be cutoff scores. You can also try IT maze, that is infant toddler meaningful auditory integration scale. You observe the child and see whether he's having any responses. Give intensive therapy for a certain period of time, usually 3 to 6 months. And after that, see whether the child is benefiting with hearing. Intensive would mean not daily, it would mean in one session you have got systematic goals.
Rahul, do you want to say anything regarding audiological as well as rehabilitation related to this?
Hello. Regarding audiological, first of all, we'd like to do some pupil evaluation or sound field testing.
With the hearing aids on?
With the hearing aids on. And to see if the responses are coming near or closer to speech banana, or at least some of the frequencies are into speech banana. And if it is not going into it, and still after giving intensive speech and language stimulation at home as well as speech therapy, pre-operative or maybe conventional speech therapy, and with proper motivation of parents working hard on the child, still the results are not achieved. Whatever we are expecting, simple auditory awareness or detection or maybe some simple discrimination abilities, then we may suspect the usefulness of that hearing aid. And optimal the power and technical aspect of hearing aid is also considered. And still, if it is not achieved, then we can say that it's not much useful.
So then, what about in terms of just going ahead with a CI? What are the other things that would come in? One is that the hearing aid is not benefiting the child, which you have seen through tests for auditory perception, because the reason that you have any amplification system, whether a hearing aid or a cochlear implant, is to give access to speech, right? Because the main aim is communication. So one aspect is the audiological and the rehabilitation. What are the other evaluations that you would need to do before you can just go ahead and CI a child, cochlear implant, put in a cochlear implant for the child? I think that we saw with Dr. Santosh Gupta's presentation with the medical and the radiological. As well as the first point that Deepa brought out in her presentation was that it's an audiological test battery. Because very often you have that the hearing aid itself is not fit appropriately. And that can lead to misdiagnosis. If you not spend enough time pre-hearing aid fitting.
I would like to add on this that there are children with hearing impairment from 91 dB to 110 dB HL. With their appropriate hearing aid, they may be able to get some spectral information. And if you know how to choose your stimuli to train them, you can get the best out of them. However, if the hearing loss goes beyond 110 dB HL, then it's difficult to say how much residual hearing the child has. And the hearing aid mostly does not give spectral information, and then it's going to be like the child should be, could be considered as a candidate depending on the other tests.
So I think what we are all trying to point out is that it is a multidisciplinary approach to the family, and the family is the center where they need to be informed what is going on, because they are after all the ones who take the decision for the cochlear implant. You have to guide them and guide them well. Some of the questions that I hear are little, when you're given cases, this person says that they evaluated two siblings, age 8 years and 10 months old. The 8-year-old child appeared to be congenital with no speech development. I'm presuming that there was no hearing. No audiological evaluation was done earlier. The parents suspected hearing loss in the second child too. Both the children were subjected to ABR and OEE. ABR revealed profound sensory during hearing loss bilaterally in both the children. OEE responses were normal in both children bilaterally. Are these children's suffering, as what is put, from auditory neuropathy? Will they do well with cochlear implants? And what is the role of genetic counseling? So maybe we can break that up, and maybe we can take up the genetic counseling part first, and then we can go on to the auditory neuropathy and with.
Again, as I said in my talk, the genetic counseling is definitely not for that particular child, because it would depend. If two are affected, if both the siblings are affected, we consider this as autosomal recessive. We straight away would say that, with of course support of other investigation, that 25% recurrence risk. What I want to tell you, which I have not mentioned, is in such cases when there is a definite inheritance pattern is known by way of our pedigree charting, then it is also, because prenatal diagnosis, I said, is not permitted. So only thing, they go in, most of these, they go into egg donation or sperm donation, because we have got now wonderful IVF programs or the centers in the country, and only way of prevention, because we talk mainly from the preventive point of view. But of course, getting benefited by cochlear implant, the other panelists can say. But this I had not mentioned, and I thought in recessive disorder there is another option given to them. Like one of the partner, you can just either have egg or sperm donation. Sperm donation is the easiest, but egg donation they have to go through whole of the IVF procedures and still can consider the next child.
I think I just want to say that with this child who is 8-year-old and where ABR and OE has been done, audiogram also may give a good information, because quite a few of the cases we have found at Nair Hospital where you get a very typical kind of notchy audiograms in auditory neuropathy. So if ABR is absent and OE is robust, the chances are there that the child could be auditory neuropathy. However, audiogram, because 8-year-old you can definitely get a pure tone audiogram, and pure tone audiogram must be done in these children wherever you can. Otherwise, ECOG for cochlear microphonic, because again if OE is robust and ECOG is also there, then you are sure that outer hair cell functioning is good. That means the chances that inner hair cells or the somewhere at the lower level of inner hair cells or spiral ganglion is the problem, and then it is auditory neuropathy. Again, there are cases where you can do LLR, that is other evoke potentials, which can tell you is it an auditory neuropathy or auditory maturation, because LLR is delayed in case of children with maturation, but it is present in case of auditory neuropathy. So definitely these different tests, electrophysiological tests, can guide you whether it is auditory neuropathy or not.
I think the other part of the question was that would they do well with cochlear implants?
We'll have to look at to experience what we see. And Dr. Charles Berlin had a big talk on this last year, or the year before last, and he had reported a number of clients improving with the cochlear implants. It depends on how much the child has, especially with these two children. Again, you see the old and the young, and the older one has nothing. So the younger one you can try and train to see if anything we can get out of the child. So after that only we will be able to see and decide. So experience says that whatever we have come across as children older, they have not been benefiting much by the intensive therapy, and they would want to go in for an implant. But if the younger ones, and if they can be trained, then it's a difference.
I think it's also a question of managing parent expectations in this kind of a situation, and maybe putting them in contact with other children who may have been cochlear implanted, who are with auditory dysynchrony. I think that could be a thing. I personally do not have any experience with children who have had a CI and have auditory dysynchrony. Also, in terms of the methodology, what is the methodology that you would use in terms of hybridization free and post. So maybe we could have anybody else in the audience who has an experience with Raki? Sorry.
I am Dr. Sharfuddin from Kerala. We did an implant in a patient with a positive OAE and an absent ABR. She's improving. She has improved very well.
If you could, I mean, in terms of specifics, is there anything that you could tell us that in terms of improvement, what are the kind of quantifiable changes that you're seeing in her?
She has, my audio, Ajish.
Okay, she has developed a hearing loss by the age of 12, and 1 year is severe and 1 year is profound. She didn't do that not benefited from a programmable hearing aid and other analog hearing aid. Then we implanted, but it's not as usual as a other postlingual adult.
True.
She has to learn and listen. Learn to listen, like as a child but CC, and with each session she's improving very well.
Raki?
There are a lot of India cases with auditory neuropathy who undergo electrophysiological measurements, that is the TT-EABR, which is routinely done abroad, and based on basically a transtympanic EABR is a preoperative EABR, and when it is done in auditory neuropathy cases, you can distinguish whether it's a peripheral auditory neuropathy or if it's a brainstem auditory neuropathy. It is seen, or there is evidence that with peripheral auditory neuropathy, these children tend to do like how other implanted children would do, whereas the ones with brainstem auditory neuropathy are the ones who do not show or there is a delay in progress. So using more of electrophysiological measurements like transtympanic EABR could be helpful in these cases where we can predict some outcome.
The next question.
No, one question. I thought auditory neuropathy generally you have a normal audiogram and the children have problem with discrimination, and that's one aspect. Other one is it possible that in this genetic type of hearing losses, the hair cells are spared and the spiral ganglion cells are directly affected?
I think I'll direct the question to Dr. Ketan.
So maybe it's not auditory neuropathy. Maybe the target cells where the destruction occurs is mainly in the spiral ganglion cells and not the hair cells. Can anybody tell me?
There are a lot of papers in literature, and even we were discussing the model panel that famous spiral ganglion hair cells, how much they contribute. Even though you have few spiral ganglion hair cells there, but if they are working effectively, then you can send the message through the auditory pathway. So there is no direct correlation between spiral ganglion hair cells and the outcome. The outcome is depending on various other factors also.
There was actually, Sydney has done a study where they have looked at all pathologies, labyrinthitis, meningitis, and seen on cadaveric dissection as to how much was the spiral cell density, and it had no correlation with the outcome. So it's your spiral ganglion, you do not need a specific number for outcome. So it could be more of your auditory processing and the central, where we studied, or Anuradha Bandwal mentioned this morning. It's mostly beyond that also that is required for good performance.
Here is a question, one which is what is known as cochlear implants in older people having presbycusis. They were not able to wear a hearing aid or not getting any benefit from hearing aids.
It all depends. Presbycusis is just one thing, but if you understand presbycusis in a real term, it is hearing loss, which is high frequency loss. So you have to give proper hearing aid trial and find out whether how much hearing aid is benefiting, and how much hearing aid is benefiting is not a benefiting, not benefiting. There is, Madam Khan said, there are a lot of tests available, a lot of scales available. Nowadays you can do videotape the sessions. I think they'll be discussing in later on lectures how to
find out whether the child is getting help or not. But when you establish a diagnosis that okay, we are not getting what we are supposed to get, then if the loss is severe to profound, then cochlear implant would be done. Or if there is a lot of low frequency hearing there, we can try electroacoustic stimulation. Either you use duet or an hybrid implant. So two things are combined together. The low frequencies will be managed by a hearing aid, and the high frequency will be managed by a cochlear implant. Though the electrode array will be a very small array, which is 6 to 10 electrodes.
Can I say something, maybe? Again, Sydney has done lot of studies. They have implanted like thousands of children and adults. So based on, they did a study just on adults, that is 65 plus, and they found this group, the 65-year-old plus adults, actually performance-wise they did just like the ones less than 65. So although the pre-operative scores were the same, the performance was more or less same for both the groups, 65 plus and less than 65. But the only problem or the issue was the ones with 65 plus did poorly in noise. So that was the only concern. Otherwise their performance was just like implanting or anyone less than 65.
I think it's not just about the age. You have to look at the other issues. If the person is cognitive, his memory is good and so many other things, then that's really not the issue. But within presbycusis, you have different types. And I don't know what the research is on, but then the type of actual, at the physiological level, there are different things happening in different types of presbycusis. But I think pretty similar kind of candidacy evaluation would be done with older people, except that they would have other issues because they are older. But it's not just specifically the age I think we should look at. There may be other things we should be looking at.
Yeah, I think if we look at the older patterns, we need to really study their nerve conduction studies and all that, because if there is degeneration in terms of whichever the auditory aspect, and another thing is all of us are exposed to noise, so hair cell damage is definite in these cases, and that's why hair cell definitely, so that maybe we think because there is a lot of hair cell damage the cochlear implant would benefit, but as Anuradha just pointed out that it's just not the age, it's what is the cognitive functioning of these people and the nerve functioning, so that those are the important issues, and we really need to do the evaluation in terms of intactness of this function.
If they are totally non-verbal, it's different, like everybody has mentioned, but if they have some amount of language and some amount of speech, then there are certain tests for older people who we can have the sentences test and the free common phrases test, and there are cut-off scores below 40% and above 75, but they need to be a bit verbal at least. If there is nothing, they are not verbal at all, then it's a different step.
One of the other questions is regarding unilateral versus bilateral implants. So will somebody, what has been put out here is, will somebody with a bilateral profound sensory neural hearing loss benefit with just one implant?
Morning session this question was covered, and there is bimodal now. You have 1 year hearing aid if there is a financial constraint or something, or I mean people have all of you have this experience fitting in money.
With hearing aid, we always say 2 hearing aids. Never give hearing aid. Give appropriate. If there is a asymmetrical hearing loss, give hearing aid, but always in both the ears should be well fitted. The same thing is applicable to even beyond 2 years. There are advantages of having 2 ears and 2 hearing aids, and maybe the other combination is cochlear implant on one side and hearing on another side. That's called bimodal. Or you could have bilateral cochlear implantation. The basic advantage, now a lot of in our country also, I think it is picking up. But as our financial constraint is a major thing. In other countries, Western countries, it is now commonly done, and even they have made attempts to go to the government and they take even other implant, the help for the other implant also, because one implant is already given by the system, but then now they have come to the state where the other implant also is justified there. One of the basic advantages, first of all, you get sense of localization. You can localize where the sound is coming better. You can get better performance in noisy situation. So these are two basic advantages of any bilateral cochlear implantation. Is the person is really making use of both the tools which are coming, then you can get an summation effect, so that's a binaural, actual proper binaural listening.
I think for that also probably Raki could help in terms of when was the age of the second implant and what was the age at the time of first implant, and what are the results based on that. You know, how do children accept if they have had either a simultaneous or a sequential, or if they have had it maybe after about 5 to 6 years of having the first implant?
The best results that have been seen is if the implant is done, especially the second one, that's the sequential one, which is within the first 2-3 years. That means the child can easily adapt to it. But that is for the age up to the age of 4 years. After that, we can see variable results. So for a child younger than 4, the gap doesn't really matter. But once he's past 4, then it matters how much is the gap. But of course, there are other factors, what he was saying about the directionality and all, that is going to be improving. But what happens is there is a lag for this side of the system to come on to the, so there is dominance for the first implant compared to the second, especially for older implantees who are now getting the second implant maybe at later age, like after age of 8 years or so.
I had the experience to just carry out a test with a child with bilateral implants, and we asked the mother as to what is it like, is it benefiting, and the thing she said that she hears, the child says that he hears the sound with crispness, the consonants are more crisp than this, and but of course that he was implanted within the 3 years time period and a lot of stimulation, and in the test his scores were very good. So there are many factors just beside both what training has been given before and many other things.
One of the questions that was put out to the audiologist is how will you diagnose cochlear nerve neuropathy?
I think Dr.Murali has explained all the tests, and those are the same tests which are used. That is basically pure tone if it can be done, emittance audiometry, BERA, and OE. These are the basic tests that one must do if you want to rule out auditory neuropathy or auditory dysynchrony. Of course, pure tone wherever it is possible. If it's not, then BERA is the only test that remains, and BERA, OE, and
I think they're only talking about where suppose the nerve probably is absent. So can you tell that, and can only an audiologist do it? Is
no.
the question?
Then it is,
and so
yes, EABR is the test. Of course, if you do OE and cochlear microphonics, you will know that, at the level of whether the outer hair cells are not functioning. And then summating potential, if you can get by doing ECOG, then you know whether inner hair cells are intact or not. And then ABR tells you whether it is cochlear nerve. And of course, EABR also will give you that status.
As we say test battery, Dr.Murali say test battery approach. He was concentrating on audiology test battery, which is a wonderful thing to follow. Always follow a test battery approach. But test battery is not restricted only to audiology. You have to take consent from other people. And like in a cochlear implant, which is a team of clinicians working together and coming to a conclusion, here radiology plays a vital role. And as we saw, discussion by Dr. Gupta, you have to identify, kept on saying that please find that nerve is present or not, please find one nerve is present or not. If there is any doubt that the nerve is not there or is thin out, then your whole approach changes, the counseling changes, and the outcome also will change as per this. So, and just to add a little bit more, the incidence of retrocochlear hearing losses, the pure retrocochlear hearing with the neurofibromatosis type 2 and then absent nerve, is really not very high. So even in congenital hearing loss cases, it is more likely that the loss will be cochlear than the retrocochlear, and you have to just do the radiological evaluation and find it out.
Also something that we have adopted at our center is that if we have no known cause for the hearing loss, we automatically send in the children, send in the parents to get a CT and an MRI done of the child before we even go on to hearing aid fitting. So because you may just think that okay fine, if the bearer is showing that there is no response, you may think that okay maybe if I put on a, as we say, a high class or a strong class hearing aid, then probably that would get some hearing. But the point is that time is of essence and appropriate intervention is of essence. So for that you need to be able to,
One more thing. When we started the cochlear implant program, it was a routine that CT scan and MRI was done. And there are a lot of old papers which says incidence of congenital malformation was 6% or whatever, 6 to 10%. Then gradually, as more and more cochlear implants are done, a lot of babies are evaluated. Now incidence is becoming 10 to 15%, or there are some papers which say 25%. So as Iti rightly said, there is no known cause of hearing loss in young babies. And when you have established some amount of profound hearing loss or severe to profound hearing loss, it is better to subject them to radiological assessment, which expedites the procedure. Otherwise, the child is going to gross malformation, and audiologist is just trying to get response, and there is no response coming. So
there are sometimes children who have benefited with hearing aids, and you're thinking about changing the hearing aid because they're due for a change, and then when you think about getting a CT MRI done is when you come to know, because we're contemplating between a hearing aid or a cochlear implant, and the child is a borderline child in terms of audiological responses or audiological information. We have been surprised at the center to find out that the child had cochlear anomalies, which we wouldn't have found out otherwise, because the child was progressing at a rate that you would say was accepted or acceptable. Until then they start plateauing, and by then it may be too late for you to think of getting a cochlear implant, or that the child would benefit really out of a cochlear implant as he or she would if they were diagnosed with the cochlear anomalies earlier. So I think it's always, everything about cochlear implants is multidisciplinary. So there's one question that is pointed to Dr. Santosh Gupta. Is he here? No. So maybe that question could be. There are some other questions which are on neonatal hearing screening program, which I think will be taken care of in the afternoon section of the day-to-day. That covers all the questions. The only thing that I would want to ask Dr. Purandare is that what then are the kind of tests, to sum up, what are the kind of tests that you will do? One, I know that, okay, fine, rubella vaccine. So the moment there is somebody who is getting into, say, marriageable age or whatever, it is recommended that yes, you go ahead and get a rubella vaccine. Consanguinity is one thing which is a preventive measure. What are the other preventive measures, or what are the other tests that you can offer, say for like Pendred or any of those other syndromes? What are the other testing that we can recommend, and what would be the average cost of any of these?
Basically, the first test which are offered to all the couples is chromosomal test. Because there are very small deletions which are associated with some kind of malformation. I always tell patients that yes, you have come to a genetics clinic to know about the specific condition like hearing deficiency. But my concern is that yes, the second, because we have had patients where first child is Down syndrome, second child is thalassemia, third child having something else. So we try and screen them for all possible disorders so that there is no, at least as far as birth defects are concerned, that prevention is done. Then torch titer routinely we tell, in spite of having giving history of rubella vaccinated, because many of them they don't remember depending on the age group, because of again IVF availability. Many women who come to us for consultation are 40 plus. So probably their time they have never taken rubella vaccine, like you rightly said. And taking the history into details and finding out if there is any other family member who is affected, offer them early neonatal screening, so that in case if it is there, their deficiency is there, that can be tackled, so that we tell them appropriately. And I told you about the egg or donor insemination in case of, that means the 50% of the genetic constitution can be altered, so that we can prevent that.
Ms. Gore, in terms of what has your experience been, probably that would be applicable once Dr. Gore talks about the infant screening program, but I know that you also run a program especially for NICU babies. So what has been your experience with that, and how is it working out with the parents and the follow-up thereafter?
I think we all saw most of the people talking about universal newborn screening, which is almost in a dream stage as far as we are concerned, because the cost involved is quite heavy. But what we are doing at Naya Hospital is all high-risk babies are referred to us, and we do their ABR and OE and DOA, which is very, very important, and we keep following them up, because sometimes on ABR we find abnormalities, as Deepa has shown in her presentation. Some of the cases we diagnose based on wave 3 rather than wave 5, which is robust. And then as these babies mature, we have found that it improves, the ABR improves. But their follow-up at pediatric department is very good, and since that's going on, they are following up with us, and we are able to keep up these babies on follow-up, so that their speech and language development can be managed well in terms of counseling the parents, and if required, the hearing aid fitting that is to be done as early as possible. But what is important is just doing one test is not what is the solution. You have to do a battery of tests. And as somebody had asked about auditory neuropathy or auditory dysynchrony, we involve neurologists also. Their opinion is equally important, because some of these cases can have HSMN, and then you need to really do the follow-up in terms of that, because the HSMN cases also have what is called as auditory neuropathy, like profile on audiological test. So finally it is the battery of tests and team approach that is what works well.
So I think to sum up is, as always, catch them early, do a battery of tests, be in consultation with each other, and guide well.
Actually, I want to ask Dr. Mrs. Pran that in cases of this non-syndromic genetic hearing loss, what genetic tests you would like to carry out for the determination? Which centers are conducting in our country, and what is the tentative cost required for them? And second question to Dr. Mrs. Gore, is electrocochleography routinely done, and should it be done in all cases prior to cochlear implant?
If all other causes of hearing deficiency are ruled out, right from chromosomal to infection to all, then we are looking at only autosomal recessive where connexin 26 gene deficiency there. Currently this is available at Delhi, at Sir Gangaram Hospital. Again, thing is that whenever the test, both prenatal diagnosis as well as the candidate detection is available, it should be done for both the partners. It costs about 5,000 rupees per person, and if you are going to do prenatal diagnosis, because most patients come to us when they are pregnant. So the whole cost goes to about, as a package, about 30,000 rupees. But then you have to take consent. Many a times prenatal diagnosis, even these centers, they don't give the results, because they say, okay, you can continue, because it is normal. Or maybe you can continue the pregnancy and then give report to the doctor, because nobody can terminate the pregnancy, because it can be misused. So prenatal diagnosis still is very much guarded, and depending on the situation it is to be told, because nobody wants to come into trouble. So prenatal diagnosis is almost not offered, only with the fear, because we have got one very good project from one of the higher centers abroad. But immediately they knew about the prenatal diagnosis, that maybe in India we might use it for prenatal diagnosis and termination, they stopped communication with me.
Madam, it is not necessary when they are pregnant. We may send the patient before pregnancy is conceived.
Yeah, then of course you have to find out carrier status by doing connexin 26. That is at about 5,000 rupees, and done at Delhi at Gangaram Hospital.
Is it in Bombay?
Yes.
With this center?
No, in Delhi.
Madam, what is telling?
It's done at Aliaba Jung. They have taken up a project. I think it's with.
It's actually being done at Jawaharlal Nehru Advanced Scientific Research Center, that's at Jakur, Bangalore. And because it's as a project at our institute, and I'm sure even Ish might be having facilities, Ms. Madhuri Gore might be able to tell us. Right now it's because it's in a project stage, it doesn't cost anything to those people who want, but then there is a criterion. We are taking only consanguineous marriages and where at least one child is affected, because it's a specific project that we are but this testing is available at JNCSR. I'm not very sure what it might cost under other circumstances, but with us as a project, it's not costing anything to the client.
That is in Bangalore.
Yes, but
may I know whether it is in Bombay or not?
I am not sure of any other center offering it in Bombay, whether we are testing. We are doing the blood collection at Aliyavarjam, but the samples are being sent to JNCSR for analysis.
No problem.
Just
test will be carried out where it is.
Yes, but ma'am, would you like to add something?
This second question to Madam Gore about the electrocardiogram.
See, most of the audiological tests, that is electrophysiological, they are the test of function, and CT by and large is a structural test. But now with the advent of functional MRI and all that, I'm not very sure if somebody can help me who has a knowledge of functional MRI. But if you carry on ECOG, what you get is cochlear microphonic, and with OAE also it is the outer hair cell function. So in audiology we believe that if you do more tests and they tally, then you are sure that outer hair cells are functioning properly, and that's the reason, just to validate OHC functioning by OAE and ECOG, it helps you doubly sure that your outer hair cells are functioning normal. Now if you do promontory this thing, then audiologists by themselves cannot do the placement. And otherwise, if you do extra tympanic or intra tympanic, then audiologists are able to do, and you get these days what is called as triptode electrode, which you can insert into the ear canal and get a good ECOG. So it's not a very difficult test procedure in the absence of ENTs, where we require them to place the needle electrode on promontory. So that can be done, and we had tried in cases where it was at with this thing, what you call with a perforation. So placing with Dr. A.G. Pusarkar when he was with us, and we had some of the cases being done. But now we plan to do with triptode electrode because we have acquired them, but we haven't yet started. So that's in the stage.
I think we're all ready to break for lunch now.